Okay, so as we finish the topic, so I was talking about this one, marijuana or cannabis. The other name is just give me a second. Cannabis. So this is important. In this one, we'll just do a quick review of that one, what you need to know. So what are the short-term effects of marijuana? It causes euphoria, relaxation, altered perception of time and space. Some people also use it for pain purpose, increased appetite, impaired memory, concentration, coordination issues, affecting motor skills, anxiety, paranoia, especially in the high doses. What are the long-term effects? It can affect your cognitive impairment, especially with the early and heavy use, respiratory issues if you smoke, produced motivation, sometimes called amotivation syndrome. So mental health risk, including the increased risk of depression, anxiety, psychosis, and predisposed individuals. What are the side effects? The side effects are dry mouth, red eyes, like the conjunctival redness, increased heart rate, dizziness, or the lightheadedness, hallucination, delusions, dependency, and then tolerance. So side effects is very common and very important. Then comes the abuse and cannabis use disorder. Marijuana is the most commonly used illicit drug, and with while not everyone who uses it becomes addicted, so 1 in 10 gets used to it. This number rises to 1 to 6, and now it's getting even more, especially before the age of 18. What are the signs of abuse? Using more than intended, failed attempts to quit, neglected responsibilities, continued use despite problems. So when it start affecting their daily life, that's when you feel like, yes, this is now getting out of the hand and now it's an abuse. What are the withdrawal effects? Like some people, mainly like when you stop using it, you won't get any withdrawal effects, but people are you who is abusing it, they will have the withdrawal effect. Withdrawal effect can occur after stopping regular use, especially in the heavy users. It's not life threatening but can be uncomfortable. Common symptoms: irritability, anger and aggression, then irritability, anxiety, and then restlessness, insomnia, vivid dreams, decreased appetite, decreased mood, headaches, nausea, sweating, and tremors. Timeline is around 24 to 48 hours, and then peak is day 2 to 4, is 2 to 6, sorry. Duration most common, they resolve within 3 weeks. So then comes the treatment. There is no basic treatment for it. All you have to do is CBT, behavior therapies, motivational therapies, rewards for drug abuse. There is 12-step program, family therapy, medication. There is no medication for that one. Then outpatient department, detox program is there, smart recovery and mental health support. So these are all the thing. Now move on to the next one. So when we were finished up to this level, then comes the sexuality and the gender. Gender dysphoria is basically discomfort or distress caused by the discrepancy between the sex assigned at birth and the person gender. So what they feel they are and what they are assigned as. Strong and then persistent cross-gender identification, desire to get rid of primary sexual sex characteristics, then repeated stated desires or the insistence that one is of the opposite sex. So all about what you are and thinking opposite to that. So all about providing the psychotherapy if they want to change their gender. Then in Canada it's open, so you can go for hormone therapy with feminizing, either go for estrogen or anti-androgen, or for masculinizing, basically giving testosterone agents. Gender affirming surgery, so changing the gender. Then comes the paraphilic or disorders. All you need to remember is the subtypes. What are those subtypes? Voyeurism, where it's basically sexual arousal when spying intentionally or suspecting individuals or unsuspecting individuals. Then exhibitionist, when looking at or fantasizing of exposing one's genitals. Then frotteuristic, it's basically the sexual arousal from touching or rubbing the genitals. Then sexual masochism. So you have to memorize all of them as it is. The definitions come and then you have to like make the diagnosis. So then sadism, then pedophilic, felishistic, then transvestic, and then other paraphilic disorders. What are the management? Giving the anti-androgen hormone to control their hormones, and then giving SSRIs, mainly their depression. Then sexual addiction is basically go for a CBT as a 12-step program and starting the SSRIs to reduce the libido. Then comes the eating disorder. The most important is the anorexia nervosa and bulimia nervosa, although there is other eating disorder too. So we'll mainly focus on those ones, especially when it comes to anorexia nervosa. Now, whenever we are talking about the complications, what are the main complications? So you can see when you stop eating, what could be the complication? Growth delays, osteoporosis, osteopenia, fractures, cardiovascular, respiratory, QT prolongation, starvation, because electrolytes will be disturbed. Hypokalemia, hypomagnesemia, hypophosphatemia, refeeding syndrome could be there, and it's very, very important, this refeeding syndrome. And then endocrine abnormalities, increase growth hormone, reduce LH, FSH, and T3. Then coming to anorexia nervosa, in this one, the athletic triad is important. What is the athletic triad? Is basically amenorrhea, osteoporosis, and then eating disorder. Some patients with the insulin-dependent diabetes mellitus may stop their insulin in order to lose their weight. What is the workup? Checking for basic vitals, knowing which electrolytes could be disturbed, BP, heart rate, CBC, electrolytes, and all that. Then you go for individual therapy, family therapy, group therapy. So it's not just about that person. It has to do with the whole family, or it has to do with the whole group. That's how they get the motivation. Then address the food and body perception, letting them know how much calories which food contain, coping mechanism, health effects, letting them know it's beneficial for their hair, skin. So because they are more motivated if you talk about these things. Then CBT, family therapy, is important because letting them know, and they will help mainly with the weight restoration. Medications of the little value is basically SSRIs. You have to watch out for depression or anxiety or mood. Outpatient and inpatient depends on how much the patient is having the vulnerable stage. Then inpatient psychiatric hospitalization is when patient is trying to do a suicide attempt. Like patient who is not happy with their bodies or with their life, they do try to do the suicide attempt. In those, they are supposed to kept in the emergency department and later on in the psychiatric ward. Criteria to admit is basically, it's very, 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 very important, this whole line. So just underline it, memorize it on your fingertips. What is this one? When are you going to hospitalize? Less than 65% of the standard body weight, hypovolemia, requiring intravenous fluid, heart rate less than 40, abnormal serum chemistry, or if the actively suicidal. Then comes the complications, or then comes the refeeding syndrome. What is a refeeding syndrome? When someone suddenly stop eating and now he is coming back to eating again. So it's basically potentially life-threatening metabolic response to refeeding or introducing the feed again in severely malnourished patient. So there is a sudden change of fluid and electrolyte that causes this problem. It can cause hypophosphatemia. This is one of the MCQs. What is the main concern in the refeeding syndrome is the hypophosphatemia, then congestive heart failure, cardiac arrhythmias, delirium, and death. So prevention is slowly refeeding, gradual in nutrition, supplement phosphorus along with it, because hypophosphatemia is one of the things. Dosage of the electrolytes and cardiac status. So mainly the heart is the one that's getting affected, and electrolytes. So with the treatment, 70% of resume in the weight gain, at least 85% of the expected levels, about 57% resume the normal menstrual functions. Then bulimia nervosa, when they eat, they just vomit. Anorexia nervosa, they are not even eating. So in this one, they eat bulimia nervosa, then they just vomit it right away. So there is recurrent inappropriate compensatory behavior as self-induced vomiting, like a binge eating and after that doing a vomiting. So this says on average of at least once a week for 3 months, it should be there. Then it is diagnosed as bulimia nervosa. So it's like this one is most important. That will help you. They will ask you, how will you differentiate between anorexia nervosa and bulimia nervosa? Sometimes they don't mention about the vomiting part, or sometimes they just mention about the weight concern. So on the basis of the tooth decay, perioral irritation, mouth ulcers, these are the ones, or the knuckles reddened or Russell sign, these are the signs that will help you to figure out this is bulimia nervosa. Sometimes they don't mention about vomiting. Okay. Weight fluctuations over the time. Sometimes they have good eating, so their weight is good. Then their weight is basically decreased. In anorexia nervosa, their BMI is always low. But in anorexia, bulimia nervosa, it will be fluctuating. So in anorexia, their BMI will be low. Then in the medical admission, where the electrolytes is disturbed, otherwise we go for SSRIs, then again CBT, family therapy, and recognition. Social challenge, the destructible social views of the female, and then or a woman, then telling them how to gain back their confidence. Binge eating is like eating, crazy eating, and it should be afterwards at least for one per week in 3 months of the guilt is there. Okay. And then mainly the CBT. So then you can see what is starvation and what is binge eating. When it comes to starvation, everything they are not eating, restricting, low BP, low HP, electrolytes are disturbed, vitamins disturbed, sleep disturbed, everything like that. Then seizures is there, endocrine problem, having amenorrhea, constipation, arrhythmias, osteoporosis, perianal, pedal edema is there, starvation and dehydration. So then you can see what is the hormones that is affected by this one. Binge eating is like they eat and after that they vomit. So there is Russell sign, like the knuckle callus is there, parotid enlargement, perioral irritation, periocular or platelet petechiae, then dental enamel aspiration pneumonia is one of the most common, and then metabolic alkalosis. Then gastric irritation and all of this one, muscle wasting, renal failure, arrhythmias, perioral, periorbital, and then vomiting, and then comes the decrease in sodium. Then comes the personality disorder. In personality disorder, usually we treat with CBTs and look for if the patient have suicidal ideation or any kind of homicidal ideation. Then comes on this part here, we'll discuss every personality. First is paranoid. They're suspicious that are exploiting and deceiving them. So everyone around them, they feel like they're trying to deceive them in particular way or trying to gain some benefit from them. So they always think negative, negative, negative. Then schizoid. Schizoid is basically neither desires nor enjoys like how the relationship works. So they, in even the family or anyone, they prefers to stay alone. So in this one, they does not feel negative, but they always like to stay alone. They don't care what people are saying, even bad things. So they have a very little interest in everything. So they like to stay alone. That's how the schizoid personality works. Now comes the schizotypal. Schizotypal is basically social and interactive deficit along with having magical thinking too. So in schizoid, they don't have any magical thinking. But schizotypal has magical thinking along with social and interpersonal deficit. Like they like to be alone, but at the same time they'd like to think about weird things and having magical thinking, inappropriate effects, unusual thinking, like lack of friends and ideas. So they come together. So paranoid is having negative feeling or negative views mainly about everyone, friends, families, or whatever. Then schizoid, it's mainly the person who is basically prefers to stay alone. And then comes the schizotypal with magical thinking along with staying alone. Okay, so then comes the borderline personality disorder. In borderline, they are impulsive and always wanted to do a suicide. They have a self-image, suicidal thoughts are there. So they don't attempt to do suicide, like kill themselves. They just attempt the suicide to gain like interest from other people or seek like attention from other people. So then comes the narcissistic, always think about themselves, like having a high, like I am the good one, grandiose personality, thinking of high about themselves and lacking about other people. Then antisocial personality disorder, they are basically the person who break things, break the properties. So they are more of aggressive people. So temper, and then you have to tell the difference. Antisocial is person who try to do the attempt of harming others as well. Then the histrionic people, they always think that they are best. He's like actress. They have a good relationship, seductive personalities, thinking good clothes, speech, like the way they behave. So it's like a histrionic, like, even if you watch some of the movies and stuff, they where the character is like there just to seek attention or just as an acting as a second female or whatever it is. So second personality, they're just there to show easily influenced, seductive personalities. They're mainly like behaving like an actress. Then avoidant personality disorder, the people who don't like to associate themselves with other people. They feel themselves, if they associate, they embarrass themselves. Like going out is not like schizoid is someone who likes to stay alone, but they don't care what people think about them. But when it comes to avoidant, they fear of embarrassing and humiliating themselves. So there is a fear of embarrassing. Okay. Then obsessive compulsive, we already know they just want to do, they are stubborn. If they like to keep the thing in the middle, it should be in the middle. If it moves a little bit away, they are always there to just correct it. So they will give you these ones, the personality disorder. There is so many questions that come from here. So you have to make up your mind how to make the diagnosis of it. Then the dependent personality is mainly the people who are very like clinging or the baby behavior towards their partner or towards the next person, and they don't like to go out. So in those cases, it's mainly the encouragement and going outside. CBT is basically the thing that you do. Mm. So it's very important to make the proper understanding about this personality disorder, because there is many questions that come from here, and then you have to make the diagnosis of that one. Then comes the schizoid, schizotypal schizophrenia. Usually we know what is how it works, so don't mix it up. But since here it's basically schizoid is basically lonely. Schizotypal is lonely, but at the same time interested in relationship too. Then comes the schizophrenia with hallucinations and delusions as well. So let me tell you, how do you difference between a personality disorder and just developed disorder? Personality disorder is something that is someone born with or developed in over the time. So it was there with them even they were 4 year old. But slowly now, why they are, and usually the personality disorder is mainly someone brought by someone. Like if I have the personality disorder, my mom or my partner will take me to the doctor. I myself might not know about it. But when it comes to an OCD or any kind of disorder, I myself, if I have insight or judgment, then I will be able to make and to the doctor by myself. Like now it's affecting my daily life. I'm there to seek a treatment. In personality, I don't think something is wrong with me. The partner or the person next to me or someone who is there will tell me now it's affecting your daily life. You should see a doctor. Let me go with you. So they will take you there. In personality, they don't think by themselves that they have problem. Okay, then comes the child psychiatry. In this one, the main important is the depression. In the depression, you need to know child, every obese child. Always think of depression. Every obese child, like whoever is overweight. Okay. So in this one, we usually go for psychoeducation and family therapy. So it's very less likely that you make diagnosis by that as early as in someone in the child by bipolar. So attachment type can be assessed in the infants in 10 to 18 months of the age using the strange situation test, in which the child is stressed by the caregiver being removed from the situation. So in these cases, they start behaving like that. Attachment problems may present as a child who is difficult to soothe and has sleeping problem, feeding tantrum, and then behavior. So the child who is crying very often. Mm. So already discussed the separation anxieties. Selective mutism is basically it's the situation for more than 1 month. In this condition, you need to just know that in specific situation they don't speak up. Then comes the autism. Autism, you need to know the diagnosis of it. How does it work? So basically, the social emotional reciprocity, where there is abnormal social as well as the back and forth conversation or their interest. Then the non-verbal cues like not making an eye contact, body language, sitting gesture, facial, because in the scenarios, these minor things will help you to figure out this is autism. It's not like they will say, oh, a patient is came to you with a weird behavior, now he's doing this, and it can give you an idea about autism. They will say very few and picky words from here, be like maybe write down, he is doing a repetitive movement and he is sitting there playing with his toys and not interacting. Now, what could it be, or what's the diagnosis? So, it could be an autism, right? They will not say an eye contact or body language. To and fourth repetitive motion can already tell you that this might be an autism. Then the developing and maintaining and understanding relationship is basically difficulty adjusting behaviors to social contexts, sharing imaginative or in making friends, absence or so they don't like to interact with people. They don't like to go around and don't make friends. They do repetitive movements. So as you can see here, the stereotype is one of the very common one, and repetitive movements is one of the very common one. So they usually like to use these words that can help you to figure out that this is autism. They will not say like things like that indirectly, especially in the pediatrics psychiatry. So you have to be very aware of the words here. Then the specifiers is basically the language impairment, intellectual catatonia, requiring sports, not making eye contact, sitting there in weird posture, just in playing with only few toys. They only like to play with few toys. Then what is other differential diagnosis of that one? Then treatment is basically telling all what school, psychological, occupational, their family, speech language, pediatrician, so everyone like whole a team-based program. Then comes the ADHD, very famous, very common, especially here, and the male is one of the most common, although females do get inattentive, but males is more impulsive type. Then its onset before the age 12 is common. There should be persistent symptoms for more than 6 months. And usually the school is the one that writes the letter to you and you have to make the confirmation and then moving on. So how do you make the confirmation? By asking mom the same questions what school has written it to you. So combined times is basically more than 6 of the inattention and more than 6 of the inattentive. So you can see from here, what are those? One, inattention is basically careless, unable to put attention at one time, does not listen, fail to complete tasks, disorganized, avoid, lose things, distractible, forgetful. Hyperactive is like impulsive, just wanted to do things right away, talks very excessively. And impulsive is basically difficulty waiting turns, cutting line, blurting out, or on the class. So they can say maybe he was hitting his friend, like a child came to you, his school write down that he was hitting his teacher. He was hitting his teacher and he's cutting his not cutting lines. He was jumping and going out of the class again and again, and he's not letting teacher talk or his friends talk in the class, and he's very aggressive. And teachers suspect of something. Now they want you to make the diagnosis. So in that case, you can go for ADHD right away. And mainly in this scenario, they like to assess how you are going to counsel the mother. So what you have to tell the mom. Difficult to differentiate from variable normative behavior from before age 4 and offer identified upon the school entry. Then what is the non-pharmacological psychoeducation, behavior treatment, parents, classroom management, and all that. What is the first line? First line is stimulant, methylphenidate, amphetamine. Second line is the atomoxylene, guanfacine. Third line is clonidine, bupropion. So hardly people go there. People usually stuck with methylphenidate or with the amphetamines. For comorbid situation, antidepressant, antipsychotic. So mothers used to ask about the side effects and benefits of methylphenidate. So go and see what are the side effects and benefits of the methylphenidate. Psychosocial intervention is the first line for the children less than 6, and after 6 you start with the medication. Usually by the time they reach to us, they are more than 6, but in the exam they can ask you when are you going to start the treatment. So the age 6 is the time when we start the treatment. Then in the oppositional one, in this one, you need to know that this person or this child, they only like to blame others for their own mischief and misbehavior. They are like behaviors causes distress and impairment in the school. Behaviors do not exclusively during the course of the psychotic or substance use. So they just try to behave aggressively. Associated with the poor school performance. So usually you have to counsel the parents. In conduct, they like to break things. Later on, conduct changed to borderline personality disorder. Okay. Oppositional is something they do like to conflict. They do like to argue with teachers. They do like to talk bad. Like, like they are in a bad way, but in the scenario, they will clearly say that he is not, or he did not break anything, or he is not into expulsive behavior. or he does not break things. So you will get to know that this is basically they're talking about oppositional one. But when they are saying that they like to be a violent person, where they violate the rules, like breaking things, entering, conning, like, all those very vulgar behavior. If anyone is there, so in this one, basically the conduct one. Arson, like playing with fire, destroying properties, stealing, so anything could be there. And usually conduct later on change to, sorry, antisocial personality, not borderline, my bad. It's basically the conversion conduct people change to antisocial personality disorder. And they do like to ask this question, which disorder can change to anti social personality disorder, or which disorder is linked with the antisocial personality disorder, or conversion can change to which personality disorder. Anything can be asked. Then again, the early intervention psychosocial pharmacotherapy is there. Then there is mainly the what kind of therapies is there. Like you just need to know the type and their indication. That's it. You don't need to know this one. Sportive is mainly for the adjustment, somatic, related to psychotic personality disorder. So in those cases, you need to provide the sport. Interpersonal is basically for the mood disorder. Cognitive is basically most mental disorder, mood, anxiety, OCD, everything. Dialectical is basically, this is very, 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 very common asked question. Dialectical is basically for borderline, because this is a pet word or pet line that can be asked for the borderline personality. What is the behavior or what is the treatment? So the treatment is dialectical behavior therapy. Motivational is basically for the people who use substance like alcohol, marijuana, any kind of like whatever they're using, opioids. So in those cases, we use. Psychotherapy we use for everything. Family therapy, you have to educate the family about everything. Then mindfulness, it is this one is basically for the eating disorder or for the adolescent problems. Then the psychoanalytic and psychodynamic is basically for the anxiety people. So you can just remember this one. That's about it. Then comes the antipsychotic. In this one, the main is they are asking which pathway it can be affected and which hormones or which are the element that got affected. So it's a mesolimbic, mesocortical, nigrostrial, and tubero-infundibular. I know it does not make sense. It's anatomy, but it's something they do like to ask. I'm not sure why. So it's a mesolimbic in this one. The high dopamine causes positive symptoms of schizophrenia. So they do like to suppress with the antipsychotics. Mesocortical is basically low dopamine causes negative symptoms of schizophrenia. So they like to do control with the antipsychotics. Nigrostrial is basically low dopamine. Tuberofundibular is low dopamine. So you can see the high dopamine is also there and low dopamine is also there. And then antipsychotics is mainly work for every kind of situation, mainly PTSD, depression, anxiety in many of the cases. Although we start with antidepressant, but antipsychotics can be used as a second along with them. So then they say all antipsychotics are equally effective except for clozapine, considered to be the most effective in treatment-resistant schizophrenia. Line is very, very important. Highlight it and read it. Then comes the choose a drug to which the patient has potential to thus past and that was used successfully in the family member. So think about this one, okay? Whenever you are choosing any MCQs, they can give you that, oh, he used olanzapine or clozapine. His dad was using it. So you can try this one because his family is successful. So he might be successful with this drug as well, okay? What else is there? So it can also be used in the Tourette syndrome, in the Huntington, ASD, impulsive disorder. So Tourette syndrome, the dementia, delirium, Huntington is something that you need to remember. Then if a patient is not regular with his medication, even in the first time they came, then and that patient came with a, let's suppose, schizophrenia episode, and that you feel like this patient is not taking the medication regularly. Instead of doing counseling, even when I'm talking about NAC or SKI, talking about anywhere, so you have to talk about long acting injectables for the antipsychotics. When a person, even for the first episode, so you have to give them the long acting injectables, okay? Outpatients should have been exposed, and they do like to ask, do you know the point of long acting injectables or not? And this is the word they want us to listen from you. So dosing at a slow dose, and then you can always titrate up. Then what are the other ones? Haloperidol, olanzapine, olanzapine are there. Then there is basically typical and then atypical ones. So usually the typical one are more having EPS, extrapyramidal symptoms than the atypical one. So usually we prefer atypical one. Then you can see the anticholinergic effects are there. Now comes to this one. You don't need to remember the doses, no need to remember the maintenance, no maximum, no potency. All you need to remember the names. What are the typicals? Only remember 3, 4 words you can easily remember. The one, the haloperidol is very commonly used. Then flupentoxazole is basically something we use in our daily life. I have given a lot of people this flupentoxazole. It's a very commonly practiced. So you can remember this one. Then you can remember this one, zuclopenthixole. So this one, I think if you could remember these three, this is more than enough. Then comes the atypical. In atypical, because atypical is something we used very oftenly. So I would suggest if you can remember as much names of this one as you can. So risperidone, haloperidol, not haloperidol, sorry, risperidone, then olanzapine, ziprasidone, aripiprazole, quetiapine, seroquel, clozapine. Like there's a lot of people who are taking this one. Okay. So this one atypical is the one that we use. So in order to potency from high to low. Then QTC prolongation is an important adverse effect of all antipsychotics, although not required, but considered getting up ECG prior to any of that. Usually it's a psychiatrist who start this medication, but you as a family physician can give it and you have to do the ECG before starting any of the antipsychotics. So they can ask you what is that baseline investigation you would like to do before starting any atypicals or any antipsychotic. So in that case, you have to do the ECG. So ziprasidone has the highest risk among the atypicals. Clozapine are warrant symptomatic baseline and follow up the ECG. Then comes what is the neuroleptic malignant disorder or syndrome. It's one of the very important one. And what is that one? It causes BARM like fever, autonomic symptoms, rigidity to the muscles, mental status, and form is basically are also seen in the serotonin syndrome. So how are you going to differentiate between NMS to SS? NMS can also be caused by the anesthetic drugs too, because haloperidol is used there too. So that's why it's important anesthesia wise as well. So NMS is basically causes the global rigidity, pallor, and no GI symptoms. But serotonin causes GI symptoms, diarrhea, vomiting. Then this person is more of a red, twitchy, shivering, and restless. So you can think of serotonin something that affects your GI. The more GI, the more blood. Then neuroleptic malignant is basically spread it whole around. That's why he's having global rigidity, the whole body, pallor, and no GI symptoms. Then comes this common causes used atypical antipsychotics. Give me a second. I don't know why is it not loading. Okay. Then comes the risperidone or olanzapine. In this one, the main thing that you need to remember is which one is the best one to the other. So you can see from here, risk of the weight gain is more in the olanzapine, then quetiapine, and then risperidone. So you have to remember this one. The weight gain is one of the main common issue with antipsychotics. And they do like to ask you about this one. It's very important. Then what they can ask from here is, as you can see, the weight gain is part is here. Which one causes the even though they all causes EPS symptoms, but which one is the highest one that causes the EPS symptoms? So you can see the highest risk of EPS is common in the risperidone as compared to the other causes too, but as compared to the other, which one? Risperidone is the one that causes high level of EPS. And along with that, it has gynecomastia, galactoria, menstrual because of the dopamine, and then prolactin level can get fluctuate with that one. Then the olazapine is basically with the weight gain. The most common side effect is the weight gain. Sedating avoid risk for the fall. So it is something that should not be given in the older people. So you have to watch out for that. Then quetiapine is basically it's a very sedating and orthostatic hypotension. So it also causes a lot of fall. So it's if they ask about which causes more fall, the quetiapine is the one who causes more fall. Although olanzapine causes two, but quetiapine also causes more fall as compared to olanzapine. Then comes the clozapine. Clo- um, Clozapine also causes a weight gain, metabolic disorders, sedating risk for fall as well, preventing severe constipation, cardiomyopathy. You have to be very cautious. Then the main important is this line, this word. It causes agranulocytosis. Although it's 1%, but it's very, very common. Avoid in the existing leukopenia. If someone is having leukopenia, in that case, is avoid the agranulocytosis. Then antipiprazole causes the akathisia and insomnia. So you can remember the main specific words. Usually they come with everything, but you need to know which one is more with that side effect. That's it. I mean, they cannot give you they can ask you which is the highest uh, incident or highest risk with which atypicals, antipsychotics. So if they ask you EPS, so if you know that everything causes EPS, but you did not read this one, that EPS is more higher in risperidone, so you will not be able to find it. That's why that you need to know this thing. Then the side effects is basically anticholinergic, alpha-adrenergic, dopaminergic, antihistamine, hematological, hypersensitivity, endocrine, and cardiac. Then neuroleptic, we already discussed, if you could remember from there, and usually we go for sportive and then give the dantrolene for the muscle relaxant, as in muscle relaxant. Bromocriptine can be used as well. Then comes the EPS, extrapyramidal dystonia, akathisia, Parkinsonism, and dyskinesia. The dystonia is basically what are you going to give benztropine and or diphenhydramine. Even for akathisia, we give the same. Usually for acute cases, we go for lorazepam, then we go for benztropine eventually. And they do like to give you the EPS side effects, starting with some sort of, like a patient was started for schizophrenia, olanzapine, now he's having this, and let's suppose the diagnosis was akathisia, how will you manage? So they do like to ask you, what are you going to choose? So in the Parkinsonism, you also use the benztropine. In this one, dyskinesia, there is no good treatment. Discontinue, reduce dosage. So in that one, we do give what? Valbenazine. Okay, so don't think about this one. For tardive dyskinesia, we don't give anything. But if they are talking about overall dyskinesia, we do give valbenazine. And then you can see here the recently the FDA has approved valbenazine. Although they says no good treatment, but if they ask in the MCQs, you have to choose valbenazine. Don't go for no good treatment. So benztropine and then diphenhydramine, like Benadryl. Then comes the antidepressant. Usually the SSRIs is the perfect one and the most commonly used one. In this one is basically how often they start working. So in this one, relief of the physical symptoms is 1 to 3 weeks and emotional symptoms in 2 to 6 weeks. Very, very important line, the timeline. Then tapering of the most side effect antidepressant is usually required to avoid the withdrawal reaction. So usually they stop and they come back to the same level. That's why you have to be very. So fluoxetine does not require a taper effect because they are long half life. So in that cases they go for that. Paroxetine is one of the good one for the sleep people. Venlafaxine is the requires a slower taper, and then the citrulline and the stelopram. That's why we always prefer fluoxetine for many people, like especially when it comes to me. I always start, if someone asks, oh, I want to start something for my depression or anxiety, which is the best treatment, so I give them an option of fluoxetine, sertraline, citalopram. If someone already looking up and they want to go for venlafaxine, then that's their own choice. So we usually start with fluoxetine because it has a fewer side effects. So you can, and especially in the adolescent people like 18, 20, those people usually like to go with fluoxetine. May be vigilant over the past 2 weeks of therapy. The neurovegetative symptoms may start to resolve while emotional and cognitives are still there. Treatment of bipolar, and then patients with the bipolar, you have to watch out for the other things too as well. Mood stabilizers and all. So in this one, the most important is knowing which one has more timeline than as compared to the other one. So fluoxetine comes first, then paroxetine, then venlafaxine, and then sertraline, and then citalopram. Then here comes the most important: when and how are you going to choose which antidepressant for what kind of treatment? So as it is very like commonly used SSRIs are like everything is like fluoxetine, sertraline, they all work at the same level. But for some people, we usually choose fluoxetine over sertraline. And